Good morning, everyone. It's such a privilege and an honor to welcome you to this year's Symposium, Primary Healthcare for the Aging. It's a beautiful day, despite the overcast outside. We've got a wonderful outline of program and information in store for you today, so thank you for your attendance. Just a few housekeeping things in order. We do have evaluations, and if you'll be sure to fill out an evaluation at the outside and make sure that's turned in. I'd like to also thank a few of those who are here today. Our guests, Dr. Ken Forty, our project officer from the our National Cooperative Agreement from HRSA. Thank you, Kent, for being here. Also, as well as our longtime friends who are here. It's good to see those faces, as well as some new friends that are here. So thank you again for attending. We were a little stalled this morning. The mayor was scheduled to be here this morning, so we were giving him just a little bit of time to get here, but I'm sure there are things that cropped up and prevented him. So if he does arrive, we're going to give him the appropriate time to do greetings to Alexandria. I'd also like to mention to you this year's theme is Cornerstones for Improving Senior Health Outcomes, Outreach Enrollment, Community Partnerships. We've got a full day, as I mentioned, with policy brief, latest issues that have cropped up around seniors and aging. We know that the face of aging has changed. We've also seen those commercials throughout that are promoting different aspects of growing older. So we're here today to learn what are those new challenges and what are those solutions that are in place that we may address them. We have a wonderful opportunity to hear from our guest speaker today, Ms. Kathleen Otte. We indeed are privileged to have you attend us. She comes with a wealth of information, wealth of experience. We were just so fortunate to have her that her schedule allowed for her to be here. Kathleen serves as the Tri-Regional Administrator for the U.S. Administration for Community Living, ACL. In this capacity, Kathleen is responsible for implementing the Older Americans Act within the 14 states and 2 territories that she serves. Prior to her work with ACL, Kathleen served as the Director of Elderly and Adult Services for the state of New Hampshire, as well as the Administrator for Assisted Living and Nursing Facilities in New Hampshire and Oklahoma. Kathleen holds a bachelor's of degree in social work and a master's degree in organizational development from the University of Oklahoma. In various leadership roles, Kathleen has planned and implemented emergency services for seniors living in both community and facility-based environments. Most recently, she has worked with federal, state, and local officials to identify best practices and lessons learned following Hurricane Sandy. She is pleased to share program information to webinar attendees to keep older Americans safe and healthy in emergencies. And I know it's challenging to sit there as someone reads your history before you, but know that we are just delighted to have you with us and share with us. I now present to you Ms. Kathleen Otte.
Thank you so much. Thank you, Karen. Thank you so much, and good morning, everyone. It is really my honor and my pleasure to be here because I'm able to come to you and speak about my passion, which is aging services, and I just feel very honored to be here with the guests that are going to be following my presentation so that we can learn a little bit about some of the emergent issues that are facing us. My role today is to talk with you about what the face of aging looks like today. And I must say to you, the Administration for Community Living is a new agency. In fact, it is the newest agency in federal government. We brought together developmental disability, intellectual disability, to work with aging services so that we can encourage people to live healthy, happy lifestyles in their community, in their home, and encourage their involvement in a long life basis so that they can stay in their homes, remain in the community, and really live a vital life that is healthy and happy. But I do want to pause for just a moment because let's take a look at the last decade. So many changes have been made just in the last decade. I always reference that because when I went to school in 1977 and I knew I wanted to work in geriatrics, unfortunately they didn't have any type of programming, no social work classes for gerontology. I knew that that was what I wanted to do, and it really wasn't until maybe the 1990s whenever many schools throughout the United States began to offer geriatric type of degrees. I think that's so interesting because we really have a population boom, yet we really hadn't planned for that. But when we look at the last 10 years, we can see so many wonderful things that have occurred, and certainly we still have some challenges before us. So talking about the face of aging and what that means, just take a look at AARP's covers. Now, we've gone from Tony Bennett to Mick Jagger as appearing on the cover of AARP. And if there's anything that says that to you, that we really have a different look about what it feels like, what it looks like to be older in the United States, all we have to do is just take a look at the cover every month to see who's there to talk about their life. I think that's really poignant. I would ask you, just as you sit there now, many of you have had experiences with grandparents, or maybe you've had a loved one that you've really respected as they've grown older and you've seen them. What does the face of aging look to you? What picture do you see in your mind's eye whenever I say to you, what does the face of aging look to you? I think when I think of that, it's a very positive opportunity. I think of my grandmother, it was just beloved to me. Fifi was her name, and I think of her because she grew old with grace. I also think of Betty White, and why I say Betty White, if you've had the opportunity to read her autobiography, you can see how she's always loved to work with people, and she's remained engaged in her community, and she's pursued her love of life, which of course was acting and doing ad-lib things. So I think of that as a very positive role model that all of us have to emulate. But again, much more importantly, we have those people that we love within our families and within our friends that we can look to say, you know, they're doing it right. I want to be like that. Now, I think that's really relevant because we are all seniors in training. And I say that with great admiration because I brought today my glasses, which of course many of you will pull yours out. You know that you have to use them too. Women, when you go in and you wash your hands and you use those Dyson dryers and you watch the air kind of flip up on your hand, do you sometimes pause and say, wow, is that what my hands are going to look like when I get a little older? And, you know, we don't, as women, wear the high heels that we used to. We lower. All of these things happen naturally, and they happen slowly, but they happen, and we don't really many times take note of that. So I encourage you to tap into yourself to make sure you are the kind of person within your family and in with your community to be the role model that you want to be that face of aging that you have admired and the one that you had captured in your mind's eye. We also have, in the last decade, really utilized the expertise of evidence-based programming. In fact, now Congress, when we go before Congress, we were able to say we use evidence-based programming to show that we can actually prevent chronic disease. Not only can we prevent chronic disease, but if someone has chronic disease, we can actually improve their lives so that they are not spending all of the healthcare dollars that are needed towards the ends of life. It's really relevant that we take note of that and capture those best practices and the evidence-based programming so that we can emulate that and continue that. The Affordable Care Act has been very, very good for seniors in many regards. We now have, through CMS, the opportunity for seniors to go in and receive a physical every year. Heretofore, before the Affordable Care Act, seniors had one benefit. They could go in and have one annual exam through their lifetime after age 65. Now we also have colonoscopies that are available for seniors, breast exams, colonoscopies, and so forth that are now part of the Affordable Care Act. And we encourage all seniors, as they talk about aging, to utilize that opportunity that's available to them through the Affordable Care Act. We literally have gone, in the last decade, from the generation that was the greatest generation to the Woodstock generation. And that's happened just within the last 10 years. And why that's relevant is we bring forward a new population of seniors that have different needs such as drug abuse, alcoholism. We have seniors this day and time where our suicide rates are skyrocketing. We have couples that come together and live together and support one another in life and in death, and many times the caregiving fatigue is just outrageous. Unfortunately, we see throughout the United States suicide murder rates because families and couples who are there and trying to remain in the home, support one another, can get overwhelmed. So I bring to you the face of aging today looks very different than it did even 5 years ago. And we need to make sure that we understand those people and what they like and what they do and how to help them and how to work with them so that we can encourage them to live that happy, healthy lifestyle. So I shared with you my face of aging, which of course is Betty White and my grandmother, and you have your face of aging that you had thought about in your mind's eye. But I say to you, I think the reality is very different for many, many people. And again, I don't want to read notes, but I do want to make sure that I share information that's completely accurate, so I will read these things. I think the reality of what we talk about is very much different sometimes to what we hope it to be. And in the United States, 10% of our seniors are abused, neglected, or exploited annually. That's a significant, significant piece of data that truly, and we'll talk a little more about the Elder Justice Act, we do not have the opportunity to say to you, these numbers are firm. It's a guess at this point, and we'll go into more detail in just a few moments. 1 in 7 seniors are hungry, and that is because their Social Security check may not stretch for the end of the month. Maybe they cannot get to a congregate meal site or have home-delivered meals in their area. Perhaps it's because they just don't want to share. They're embarrassed that they are hungry. It's a significant problem in the United States that really we don't bring to the forefront. 36% of older women live alone, and many of them are very lonely, and many of them are very isolated, and many of them are very subject to being exploited financially as well as in emotionally and other ways as well. And 3.6 million of our seniors live in poverty. The median age for men throughout the United States is about $27,700, and the median income for women in the United States over the age of 60 is a little bit less than that, $15,300. It's really challenging whenever you talk with many women who are older, many times married for 40 years, their husband passes away or they leave them, they divorce, and we also are seeing more of that. And they are there without really anything other than their Social Security. One of the things as we age is to become really relevant in what our needs are and to plan. And again, we'll talk a little more about that in the presentation today. But I think taking responsibility to recognize that we need to be able to take care of ourselves and our families in the appropriate ways by planning and saving, by discussing and sharing information with family members. And again, just a couple of more statistics to make my point. 80% of people over the age of 60 have at least one chronic condition, just one. But then 50% of that 80 have 2 or more. And again, I think the statistics are there. We recognize fully that that's the most expensive part of medical care is in the latter stages of life. So I bring that to your attention in that we have an opportunity through the Affordable Care Act, through prevention measures, through evidence-based, to really age in our communities healthily and also with real feistiness about how we want to control our aging bodies and also our emotional expectations of what it is to grow older. It does take a lot of courage. And I think as healthcare professionals, which of course many of you are in this room and we have federal partners here, we have to learn to work together. And I'm very proud to say I'm a new federal government employee, at least I still feel new, 4 years, but I have seen such an important partnership where we're coming together to see what we can do to help one another. Karen was kind to talk a little bit about Hurricane Sandy. Never did I see anything come together as much as it did whenever we were in New York. And we had people who were over the age of 60 living in high-rises with no electricity for a week. That community came together. Senior centers had more people coming in and volunteering than they knew what to do with. But we made it work. People helped people. And we have to get that sense of community, especially focused on the needs of our seniors, so that we can implement a healthy and happy plan for their lives. And also there's a lot of reward for the younger people to help serve seniors as well. I also want to talk a little bit about HIV/AIDS. CDC says that the people over the age of 50 have the highest rate of HIV/AIDS. And because we don't think we can get pregnant, so we don't worry about it when we get there to that age. But you know, I'm here to tell you, older people have sex. And we need to be able to get the word out that it's okay to ask for help and assistance, but more importantly, to be aware of some of the risks that are available and presenting themselves when they engage in sexual activity. And again, we have Dr. Stephen Karpiak who will talk more about that today. But just to say, there's a significant part of our population that are older that are very embarrassed to tell and to share that they are HIV positive. And that in and of itself is extremely dangerous. I also want to talk about elder justice, which is really my passion and where I feel so strongly that we have an opportunity before us if we act upon it and take note. We do not have comprehensive data throughout the United States to gather and to collect statistics and data on elder abuse. Every state has their own method. Every state has their own set of definitions. Every state counts it very differently. And when you look at each individual state, you will see their data. It shows skyrocketing numbers. You know, people who are exploited. Because when the economy turns, or when family members are losing their jobs, they turn to their grandmothers or their mothers and their fathers that have that small check that comes in, and instantly it may become theirs. There's a little bit of entitlement there. And we know that when we look at our adult protective social workers, this is what they tell us, that really they're not meaning to do harm, but they are taking their grandmother, their mother's money, and they're utilizing it for themselves because they are out of work or something along those lines. That's what our state statistics say. As opposed to child care, and we've had, for the last 40 years, we've had statistics throughout the United States that show and demonstrate children's abuse, neglect, and exploitation. We know those numbers, and we have a great budget through the Administration of Children and Families to help work within those realms. But we don't have anything for seniors. Elder Justice Act was passed as part of the Affordable Care Act. It was passed, and again, you'll get to hear my friend Bob Lancato talk a little bit about that because he has been so persistent about making sure we're all aware of this very, very important act. But unfortunately, it was not funded, and that is key. We passed it, but we didn't fund it. It offers promise to our adult protective social worker in every state because, like me, I went to school to be passionate about seniors. And I still feel that way. But I did not like to work with numbers, which is why I went into social work. You know, our social workers are having to do these very complicated forensic accounts of exploitation. They need training to do that. They need expertise to do that because that's not a national phenomenon of social work is to go into working with numbers. So again, I say that as a mere example. We have the opportunity to fund education about adult abuse and exploitation and neglect, but we haven't been able to fund it yet. And I urge all of you to hear that call and don't let it settle because we've got to be proactive in this area. Quite frankly, 2.1 million people in the United States receive some type of abuse, neglect, or exploitation. 2.1 million seniors experience some type of exploitation, abuse, neglect. We really have nursing facilities that have methods in place to report those types of things, but for the people living in the community and our disabled partners as well, we do not have the mechanism to actually reach those people. And just as HIV/AIDS, people are very embarrassed to come forward and say that they've been exploited. So I bring that forward because June 15th is Elder Abuse, Neglect, and Exploitation Day, but Elder Abuse Day, June 15th. You know, many of the countries, the developed countries and the underdeveloped countries, came to the United Nations and said, we need something someday that we can denote and pay attention to this. And so I urge you, if you have any interest in elder issues, elder abuse, any way that you think that you can take a role in your community, I would encourage you to go to AOA.gov. That's for the Administration on Aging.gov. There are toolkits. There's a wealth of information there. And what it does, it raises your awareness as we go forward about what is elder abuse, neglect, and exploitation. I mentioned to you that, and Karen was very kind to talk about what I serve. I feel very blessed, and I'll tell you why. I represent 14 states and 2 territories that truly set the pace for the nation as it relates to aging services. I inherited all of their good works, and I really appreciate it, and I always thank them for that. But it feels so wonderful to be the first in the nation to open up in New York City an LGBT senior center, the first in the nation to do that. And I have to tell you, I was there on the opening day, and I have gone back to visit, and I can't tell you the spirit of what you feel when you walk in there. There's energy, there's vitality, there's comfort, there's community. And it's beginning to happen throughout the United States. But again, it started in New England and down through the Mid-Atlantic, and it grows throughout the United States. But we're able to tap into opportunities for seniors that truly we never have before. And again, this is a very interesting decade because we're continuing to make those changes. Not just LGBT, but also specialties for seniors. Actually, we have senior centers for the blind, which if you haven't seen them, they're wonderful because they are there to help serve that population, and people who are blind have activities activities that are focused primarily upon what they are capable of. Even bowling, things along that line that we don't think about. And they love it. They are thriving, and they're very, very appreciative because we're actually meeting their needs in the community. There's a variety of type of senior centers, but what we've tried to do also in the last decade is to really focus on consumer direction, to make sure seniors are in control of the care that they receive and the services that they receive. And we've worked so hard within our aging network. And today another speaker that you will hear from is Sandy Markwood from the Association for the National Association for AAAs, Area Agencies on Aging. We've worked very, very hard to make sure that in the forefront and actually directing the plan of care are our seniors. So that's another thing throughout the decade that we can say, state to state, we've been able to do very successfully through our Area Agencies on Aging and also our Aging and Disability Resource Centers. Community involvement, civic involvement, why does that ever wane when you retire at 60? I think we have to remain engaged. And again, all of you, seniors in training, just like I am, I really need to instill that in you. Give back to your community. Give back in ways that you really hadn't thought about. Pursue those things that make you feel a little uncomfortable. If you really don't care for public speaking, push yourself a little bit so that you can lead tours. And I just went to the Poe House in New York City, and there was a gentleman that was there that was retired that had a passion about Edgar Allan Poe. And he shared that with us, and it was a wonderful thing. Find what drives you and your passion and give back to your community, because as you grow older, this is not only helping you, but also those people who are coming behind you. And recognize what family means. I had the honor of speaking at the United Nations on behalf of Assistant Secretary Greenlee. It was a very career high for me. I was so honored to be there. But I must say this to you, what was really amazing to me is that we were there to define family. What does family mean? Russia sat next to me, and they had prepped me, said, you could encounter a little bit of a discussion because Russia recognizes the nuclear family as the family. What we know is we have an invisible population out there. We have seniors and grandparents that we really don't talk about as part of the family. So an invisible population that we want to bring forward and be visible. So expand your concept of family. Include those people who are seniors so that they play a vital role in their life and in your life as well. And again, volunteerism, I can't underscore that enough. I think that is so very important because it also helps us fight chronic disease as we grow older. It keeps us engaged. And one of the things that I would say to you as another concern is, Alzheimer's disease. And again, we have a presentation on that this afternoon. But do you know that we don't have enough people who are coming forward to volunteer to be in studies for Alzheimer's disease? This is critical. This is something we can do. Even with dementia, we can give back and be available to help others who are coming behind us with this very, very serious disease. I also want to touch upon something else, and that is our responsibility to grow old with dignity and also to die in dignity. We as Americans don't talk about dying. We don't feel comfortable. And yet we don't even do things that are not so uncomfortable, like preparing durable power of attorneys or having living wills set up. But end-of-life issues are where we need to go in the next decade so that we can begin to bring our families along with us, so they can help us make decisions, so that they can do what we want them to do as we grow older. For ourselves. In other words, utilizing your community and your families to help you live the life that you wish to live and die the way you wish to die. I know that that's kind of an unsavory topic to talk about when we say the face of aging, but if we don't recognize this and we don't deal with it and we don't plan and we don't encourage younger people to begin to save for their older age and we don't begin to talk to people about their health and stopping their smoking cessation or things that really could help them live a healthier lifestyle, then we've really lost the battle and we have not been good stewards of aging services. So I'm going to close by just saying thank you for being here today, because I think many of the things, the topics we're going to be addressing are so vital and so important. But I also say to you, I urge you to think about yourself, think about your family and what you can do to be proactive. We are all seniors in training. We truly want to make the best we can for this life. And as aging professionals, actually that's our responsibility to do so. Remember those things that are important, things such as the Elder Justice Act. Things as if the Elder Justice Act, because it will affect all of us as we get older. It is an opportunity that we cannot let pass, and we need to make sure that we keep things in the forefront. As you go throughout the day and you listen to these other speakers, you will gain a variety of information. Yeah, a lot of data, a lot of important information that you can take back with you. But if there's anything I just want to share with you, please be aware of issues that affect seniors. Take action on those feelings you have. Be passionate about what you do, because many years from now, you will be enjoying and reaping the benefits of the seeds that you have sown. So I thank you very much for your attention this morning. It's an honor to be here. I look forward to the rest of the day, and I hope you will as well. Thank you very much.
Kathleen, I don't think I did you justice in those few words that I spoke of earlier. You talk about a quiet storm. I mean, you really are a repository of a lot of information that I'm sure many of these attendees will seek you out throughout the day. So thank you. There are a few words that really struck home with me throughout your presentation is seniors in training. And you're absolutely right. The glasses and the heels are the telltale signs that the face of aging has changed. I know there's a new number that's associated, the 55 plus actives. I kind of hate to hear that, but it's around the corner. So thank you again. And earlier on, I was remiss in acknowledging the North American management staff that are the epitome of professionalism and carrying the work through for the last few months. They have been diligent on preparing such high speakers such as you, Kathleen Ott. So if I may just acknowledge North American management, if you just want to raise your hands and say hello, I have just been honored to learn from you guys, and I thank you so very much for the support. So we're going to move on so that we stay a little bit as much as possible. But when there's such jewels of information, we have to move forward to share. So like me, I hope that you gained a lot of the nuggets and bullets that Kathleen had to put out for us as we begin our day. So next we'll have our next plenary session, and we'll take just a couple minutes break as we reset the table, and then you freshen up, and we'll be back with the plenary. So Johnette, if you'd like to. Yes.
Good morning, everyone. My name is Johnette Payton. I am with the National Center for Health and Aging, and I will be moderating this morning's plenary, which is Outreach and Emerging Issues at the 2014 National Primary Care Symposium on Aging. We are very honored to have such a great selection of speakers. And each speaker will speak about 10 to 15 minutes, and at the end, we'll have questions. So about 10 to 15 minutes for questions. The first speaker is Andrea Bainbridge. She is a public health analyst in the Bureau of Primary Health Care within the Health Resources and Services Administration. Andrea's work has focused on outreach and enrollment activities, ACA implementation, as well as other payment and delivery system reform issues impacting health centers. She has completed detailed assignments at the Centers for Medicare and Medicaid Services, the National Conference of State Legislators, the Department of Justice, and the Assistant Secretary for Preparedness and Response. Prior to working in the federal government, Andrea served as a counselor for adults experiencing severe mental illness and co-occurring substance use disorders in Montgomery County, Maryland. Following Ms. Bainbridge, we will have Dr. Stephen Karpiak. Dr. Karpiak has a 25-year research career in neuroscience and immunology on faculty at Columbia University Medical School. He served as a science advisor for the World Health Organization in Geneva and has given rounds at every major teaching hospital in the U.S. and internationally. For the last 11 years, he has directed research on older adults with HIV at ICRIA, AIDS Community Research Initiative of America in New York City. At ICRIA, he initiated the pivotal efforts Research on Older Adults with HIV, the most comprehensive study of older adults with HIV and AIDS. He is an investigator of the NIH-funded WIHS cohort, focusing on older women with HIV. Dr. Karpiak was appointed to the faculty of the NYU College of Nursing in 2010. Our last speaker will be Robert Blancato. He is the president of Motts, Blancato & Associates, with offices in Washington and New York. Preceding this, Bob had a career in public service spanning more than 20 years in both the Congress and the executive branch. It included 14 years as a staff director on the U.S. House Committee on Aging from 1977 to 1991. In 1993, he was appointed by President Clinton to be the executive director of the 1995 White House Conference on Aging. 10 years later, he was named to the Policy Committee for the 2005 conference by Representative Nancy Pelosi. Bob currently serves as the national coordinator of the 3,000-member nonpartisan Elder Justice Coalition. He also serves as executive director of the National Association of Nutrition and Aging Services Programs. In 2013, he became volunteer state president of AARP in Virginia. So if you guys will welcome me in welcoming our speakers.
Good morning, everyone. Good morning. Before I get started on today's presentation, I just want to get a sense of who my audience is. If anyone's here representing a health center, could you raise your hand for me? And then of you, how many of you were involved in any of the outreach and enrollment activities that took place at your health centers? Okay, great. So some of this will be a little bit of a repeat for some of you, and for others, you'll learn a little bit about what I'm starting to talk about now. So as I was introduced, I work at HRSA, and I've really been intimately engaged for the past year in outreach and enrollment activities and the funding that HRSA provided to health centers. Last July, 2013, HRSA awarded approximately $150 million under the Affordable Care Act to support health center efforts to enroll uninsured individuals across the nation into affordable insurance options. In addition to that, we also awarded $6.5 million in supplemental funding to the primary care associations to assist health centers with some of the more state-specific needs that they had as they learned what they needed to do to become involved in these activities. As many of you may know, this type of work, outreach and enrollment assistance activities, are part of what health centers have been doing all along. But with the Affordable Care Act coming into the picture, there was a little bit more focus on the new affordable insurance options that were made available, and that included anything that was offered through the marketplaces, so qualified health plans, Medicaid, and CHIP. In December of 2013, HRSA awarded an additional $58 million to address the anticipated increase in demand for these activities, because there was a little bit of a surge that started to come before that, and then we really saw a big push as healthcare.gov started working more consistently. So that was really a big push that the health centers needed some of that additional funding for that March end date. As I was preparing for today's presentation, I was thinking a little bit too that these new affordable insurance options that I just described do not include Medicare. So when we think about the face of aging and how that has shifted a little bit, as Karen said in the beginning, 55 plus, or when we talked about what triggered in our minds this face of aging, it could start as early as 50, or it's really this group that we can think about in terms of the work that we've been doing on outreach and enrollment, 50 to 64. I know that health centers in some communities spent some time dispelling myths or helping people understand what was Medicare's role in this. Would there be an individual responsibility fee for people who weren't signing up through the marketplace? So now that I've outlined a little bit of the funding that HRSA provided to health centers for this work, in response to that, health centers employed a variety of different strategies across their communities to provide this outreach and enrollment assistance. And this varied from whether it be providing general education or answering very specific technical questions about plan options. Also, some health some health centers found it useful to use classroom assistant style formats where they could have someone presenting on a screen and individuals sitting where they had computers that they could log into the system and follow along, so that it could be one assister helping a lot of people at one time, with some various other assisters being on hand for specific questions. So it really varied. Also, health centers leveraged many existing partnerships in their communities, as well as having created new ones. And I know I heard through the primary care associations that a lot of communities were partnering with health centers and AARP, for example. So it really varied widely, and I'm sure some folks that are in the room could speak to even more detail than I'm able to right now. Also, I will note that what worked well in one community may not have worked as well in another community. So really, some people found some messages resonated better in some areas or among certain populations than others. So for example, I heard that really in some communities, radio messages really hit home with folks in the community, whereas in other places, had they tried that, they didn't get as overwhelming of a response to that as they did word of mouth from trusted friends and families. So as a result, I'll talk a little bit now about the numbers that we saw as we had health centers reporting their numbers to us over the course of this year that we've provided this funding. As a result, through March of 2014, health centers reported supporting nearly 14,500 trained outreach and enrollment assistance workers and assisting more than 4.7 million people in their efforts to become insured. And that really exceeded their original projected number to be assisted by more than 1 million. So they did a phenomenal job, and I think everyone could acknowledge that there were little bumps along the way, and I'm really in awe of the work that they've done. In the January to March quarter alone, health centers added more than 5,000 outreach and enrollment workers and provided assistance to more than 2.6 million people. So if you look at that total number and then you look at that one quarter, it was a very busy time. So I'll also note that we have provided ongoing funding to health centers to continue their work in outreach and enrollment assistance activities. So that's folded into their health center base awards. So there's really a commitment from HRSA for health centers to have this as an ongoing activity. I have plenty of resources if anyone's interested. We have our technical assistance website that's available for health centers for any questions or training materials or any frequently asked questions at bipic.hrsa.gov/outreach and enrollment. I'm happy to answer questions when we get to that point, and thank you very much.
Thank you.
I want to thank the organizers for the invitation this morning. Last night I was confronted with the fear that maybe I was going to give the wrong presentation. I had a choice. I could talk about multimorbidity, really exciting topic, and it is, or sex. So the organizers told me to opt for sex. So I have no problem with that. And I want to see if I can get this going. Is this just, oh, here we go. I should know how to do this after a lot of years. My mothership is a CREA, the AIDS Community Research Initiative of America. I know that's a lot to say, but which we opt for saying just a CREA. But it is my mothership, and the issue of HIV and aging has come to the forefront in the last 5 years, with the CREA taking the lead on it. In 2008, there was a annual HIV and Aging Awareness Day established by the government. Then there was a White House conference on HIV and aging in 2010. Then HHS would introduce an amazing toolkit to educate professionals as well as older adults with HIV. And then in the last part of the fall, we had a U.S. Senate hearing on HIV and aging. So the issue is quote-unquote hot, and for good reason. We have in the U.S. now almost 1.3 million people living with HIV/AIDS, and this is a disease that is manageable but not curable. I want to make emphasis on that. People can be given ART, antiretroviral therapy, but they can therefore live long lives rather than have a truncated life, which was typical of the early parts of the epidemic. Nonetheless, it is a manageable disease, taking its place along other chronic disorders in the compendium. Just to give you an idea of numbers, there are, again, about 1.3 million people. Of these, half are over age 50 by next year, and that by a year 2020, almost 70% of the entire USA population with HIV will be over age 50. Age 50 was chosen by NIH, not by AARP, by the way, as a cutoff point, but it's important. It was said today how aging begins at a very earlier age, much earlier than we think. So this is a very important statistic. We're going to cross this line very, very soon. And already in the major metropolitan areas of this country, we've already crossed that line. 1 in every 6 new HIV diagnosis occurs in someone over age 50. That's a very high number. You know, if you look at 6 people sitting in front of you and say one of them, okay, is older and is likely to be tested positive for HIV, that's huge. Now, if you remember a couple of slides ago, HIV is the initial infection. People can live with HIV unknown to them for about 10 years before it manifests itself as AIDS, which is really the terminal stage of this illness. And this is the issue I want to talk about today, is how to avoid getting to that point of AIDS. There are many jokes about aging and sex, and they all can make us chuckle. And part of the reason they make us chuckle is because, for some reason, we dissociate sexual activity from age. And the people who are the worst offenders of that are physicians. This is a truth. If anyone in this room wants to admit to being over 50 and thinks back at their sex life today, last week, last month, versus when they were 20 years old, the reality is that getting older and having sex actually gets better. Study after study shows this, but no one knows that, least of all the young, except those who get involved in December, spring relationships. One of the most important studies done on aging was done by Dr. Lindau, who's at the University of Chicago Medical, and she showed that throughout one's life, sexual activity remains very high, and this is true of both men and women, and that if anything, sexual activity goes down for 2 reasons. 1, lack of accessibility to a partner. Hello? In order to have sex, one needs a partner. Why they don't include masturbation or other sex toys, I don't know, but I didn't create that definition. And the other is illness. Of course, illness is impedes functionality and therefore having sex. In 2011 and 12, CREOS was the first organization to begin to create a public awareness campaign about sex in older adults and HIV. And anyone in this room knows that these are very, very costly efforts. And we have to thank the New York City Council, which has funded CREO to the tune of about $1 million a year, less in these lean years, to get this issue out. Most of CREO's efforts are educational, and we train in every single senior center in New York City, of which there are about 365. Kathleen alluded to them earlier. And this has sensitized the population to this issue. What's amazing to us, and our educators especially, is when they go out to speak about these things, people are, if you will, the higher-ups are reticent about this, but the person, the aged people, the older adults, they talk about it easily. And they talk about it in ways that are really kind of refreshing. So I think we have to give them the benefit of the doubt more often than not. These are posters from our last campaign. These were in bus kiosks through most of New York City, but particularly in areas that were hardest hit by HIV. We have a new campaign actually beginning next week. This data is actually the data that concerns me the most and CREO the most. The number of people diagnosed with AIDS, okay, at initial testing increases with age. What does that mean? That means that a person lives with HIV for maybe 10 years, 8 years, 10 years, 12 years, and then at some point along the way they get tested and they find out they have not just HIV, but AIDS, okay, which is a terminal stage. This is the collapse of the immune system occurring. Now, treatment can reverse that. Nonetheless, this person has escaped testing for a decade, for 1 decade. And these are people who are at risk. There are high at-risk groups, clearly gay men, but also in New York City, half the people infected with HIV are not gay identified. 1/3 are women, okay, which we too often forget, and the others are heterosexual men. This is not a disease of only gay men. And if we look at the world stage, the global stage, we just finished work in Uganda and South Africa, it's 50-50, 50% men, 50% women. This is not a gay disease, please. Nonetheless, it affects that community enormously. But you can see the progression of a diagnosis of AIDS increases with age. These people are falling through the cracks. It's that simple. So how do you get them into testing? This is the whole outreach effort. It's a considerable one, and no one's figured out that paradigm yet. But it is the challenge that we face. The other challenge is that next year, 2015, comes the tsunami. The aging population in this country comes not gradually over age 50, but all at once. And it will be a shocker to this country and to the systems that provide support about how to deal with that. At the same time, these are the peers, people over 50, of this population. And people generally have sex with peers. There is the December-January relationship, but these are rare. And people whose children go away to have leave the nest often are followed by divorces and followed by changes within the immediate home environment, where then the mother or the father, independently or unbeknownst to each other, which are primary positions to think about, become sexually active in a world, okay, where they are at risk for HIV as well as other STIs. Now, this is a big campaign that we began. This phrase, age is not a condom, was actually developed by a Princeton graduate and doing work in the Royal Academy on a Fulbright in London. And it's worked very effectively. This has been up on bus kiosk in New York City and has developed a lot of kind of conversation. It's a good place to start, if you will. What health providers need to know. All older adults are at risk for STIs, all. Remember that. Think about yourself. If you're the physician, nurse provider, you're looking at a patient, they're like you. They're not any different. Everyone is uncomfortable talking about sexual history, particularly the provider of health care. I know that younger physicians are much more trained to engage their patient. But older providers are not, simply are not. In fact, we're still in a discussion about how to tell people that they should get tested for HIV in healthcare environments 2 years, 3 years after we actually implemented that law. Older women are biologically at higher risk. This is due to the thinning of the vaginal lining, but also there seems to be an increased susceptibility to virus binding in the system. Erectile dysfunctional meds are out there. They create, if you will, Romeos. My parents both lived in assisted living, and when I gave a speech there, what came to my ear was all the Romeos these women were dating and didn't know it. There was like 8 Romeos in this 250-person facility, and there were 8 men outside the facility who were dating most of the women in that room, but unbeknownst to each other. So erectile dysfunction, found it in Boca, they say, give someone a car and a Viagra and they become a Romeo. And for older men, this is an extraordinary position in later life, position of power, I might mention. And in that context, and I think Kathleen mentioned it today, older women are willing to take risk for the purpose of achieving intimacy and security. So women will place themselves at risk so they can have those 2 other factors. So you should consider that, especially if a woman talks about being sexually active. Great, especially if she's not married any longer. But think about the consequences and the motivation for doing that when you're counseling your patients. And I mentioned spring-winter relationships. They're actually far more common than I would allude, and people really don't know how common they are. But they set up a situation that's very good, but also very treacherous, and wherein people can be taken advantage of very, very rapidly, not only financially, but also medically. Older adults do not begin the conversation with their physician about sex. We know that. We know that from study after study after study. It is incumbent upon those of you who provide health care, those of you who can, if you will, cause people to have a conversation. to encourage them to have a conversation about sexual health. This is a new word, if you will, in the compendium of healthcare literature. But sexual health is really very, very critical to a person's well-being, to their being happy in life, and to actually having successful aging. ACREA, with the American Academy of HIV Medicine and the American Geriatric Society, began an effort to establish guidelines for clinicians to use as they interact with older adults, be they positive or not. And this 2-year effort with about 20 of the leaders in HIV and aging research came together and produced a very large document, an 80-page document, that we knew would change over time. So we put up this document on a website, and in that website are many details or many other ways of looking at how clinicians should best interact with older adults and with those older adults that have HIV. So I have cards for this website. It was just launched about 4 or 5 months ago, and it has really gendered a lot of activity, far more hits than we had actually anticipated. And it is a changing, it is a moving target. So if you want some guidance and some hints or some resources, this is the place to go, HIV-AIDS. These pictures of these individuals who were up on the screen earlier, these are all people living with HIV. Their average age is 62. And they may look older because HIV can do that, plus a lot of the context in which people have gotten HIV. The stigma of HIV is alive and well. In fact, I think it's far worse today than it was in the 80s, in which it was horrible. But people are afraid to disclose, and this population is very hidden very often, particularly from their primary care physician. And they are alone. They are lonely. Depression is rampant in this population, which contributes nothing to health and is not treated well. So that often sex becomes a way of buffering this depression, and that sex is more often unprotected and unsafe, not only for them, but for their partners. This is a conversation we all need to have, not just about HIV, but all STIs. Thank you.
Ruin my plan if it doesn't work. Here we go. Good morning. I'm going to stay here for a very practical reason. I was given a speech recently, and I didn't have a PowerPoint like I don't have this morning, and I went up and I put my papers on the thing, and I deleted a subsequent PowerPoint from somebody else who was supposed to speak later. So I think I'll stay down here so as not to ruin anybody else's PowerPoint. I'm Bob Blancato. It's an honor to be here, and thank you for the invitation, and it's a special pleasure to, how many folks in this room were here over the weekend? Raise your hand. Do you live here? Most of you live here? Okay. I don't know if you heard the biggest event that happened over the weekend. It wasn't about the Triple Crown. It wasn't about the Heat beating the Spurs. It was over the fact that, and I'll start with this, how many people in this room are tweet on a regular basis? Raise your hand. Uh-oh. Well, the biggest news of the week is that the newest entry into the social media tweet world is the CIA, whose first tweet was, "We can neither confirm nor deny that this is our first tweet." So, welcome to Washington, and only in this town would that be a story. It's a pleasure to be here. I'm very happy to be with a lot of my colleagues, but especially Kathleen, who I've known and worked with for many years, a great leader in elder abuse prevention, but great work at the ACL right now. And Sandy Markwood, who you'll hear from later, who is, she and I are sort of, reaching the point where we stop calling ourselves old friends because we're both in aging. So we're friends of long standing. See, we don't want to. And to be at this symposium is very important. The importance of primary care right now and primary care practices grows as the population ages in this country. It came to light just this week in the VA health scandal, if you think about some of the rationale and some of the reasoning that people were talking about, including the acute shortage of doctors, especially primary care physicians, to handle a changing and older population within the VA. Our concern is the shortage of primary care physicians, but there's great hope that initiatives like the Affordable Care Act are going to help reduce this shortage in the future. In our move toward greater patient-centered care, primary care must be stressed and will be stressed as we go forward. because it's often a person's first point of entry into the healthcare system, and it's also their main continuing point of contact. So being part of this conference is a real honor for those of us who work in this field. You know, I come in several capacities. You know, I wear so many hats that it's amazing that I'm bald. They mentioned about ARP. I am a volunteer state president. Don't listen to that title. It's no longer the American Association of Retired Persons, because most of the people in ARP aren't retired anymore, because eligibility is 50 and above. So think about that. But I enjoy this work. My work with the Elder Justice Coalition and the Nutrition Group. But each of them play a role in your conference today. ARP was an ardent supporter and remains an ardent supporter of the Affordable Care Act, which has as one of its greatest commitments and successes the work in federally qualified health centers, who are now serving 21 million people in this country. With 1 in 15 Americans are going there for primary care. The Affordable Care Act has helped strengthen these centers. The Affordable Care Act's focus on expanding preventative care for older adults, a hugely important decision. The 50 million Americans on Medicare who now get a Welcome to Medicare physical, and then they have a personalized prevention plan going forward in the future. And you know, with the Elder Justice Coalition, that was part of the Affordable Care Act. It ultimately became part of the Affordable Care Act. And it has as its undercurrent the commitment to fighting elder abuse, neglect, and exploitation. And I'll talk more about that in a second. And with NANASP, you know, the importance of looking at the broader issue of nutrition and its value in relationship to good health and to helping caregivers. You know, prevention is at the heart of primary care, and health promotion, patient education, and communication between patient and physician and others in the system. And you have a handout, 2 handouts that I've provided. That one is some links for future contacts on information I'm going to give this morning, and the second I'll talk about in a second. But I want to go back to elder abuse for a second. Kathleen did a wonderful job of sort of painting some of the pictures about it. We are 6 days away from World Elder Abuse Awareness Day, which has become a very significant celebration because President Obama elevated it a couple years ago by signing a presidential proclamation declaring it such in the United States. But it's a time to focus on this growing but still fairly silent problem of elder abuse, with 1 in 10 people over the age of 60 being a victim of elder abuse today. They did a study that I was involved in about people who are victims of financial abuse. They estimate they lose up to $3 billion a year. Victims of elder financial abuse lose $3 billion a year. But take it one step further. For them, some of those people, that's their life savings, out the door, never to be seen again. And we talk about these numbers based on reported cases. But for every case of elder abuse that's reported, up to 23 other cases are not reported, based on studies that have been done. So what is the key to the solution here? First of all, the most essential thing, you cannot stop what you don't report. Mickey Rooney is the best example you can think of. Okay? A guy who is a legend, multi-generational legend, who in his late 80s became a victim of elder financial abuse by one of his stepsons. He reported it, but he went one step further. He came to Washington and testified about it, so the rest of the country could understand what the issue is and how it could affect people rich and poor. It's about awareness. It's about education. It's about training. You need to know when you are confronting elder abuse. Too many old people go to emergency rooms with bruises. The assumption is they fell. Maybe they did, but they could also be a victim of physical abuse, because our forensic work is not as advanced in elder abuse as it is in child abuse, and we've got to work on that, and the Elder Justice Act would do that. We need to think about closer ties between federally qualified health centers and adult protective services across the country, especially when you're serving a larger number of elders in your center. We need to be looking at results of grants that have been funded by the Administration on Aging that will allow funds to be used to implement and test new measures and approaches to identify, intervene, and prevent elder abuse, neglect, and exploitation. I want to focus on one of these grants that we're involved in, which I think has great promise for the future. It's a grant that is being run by the state of Texas that will validate a short 6-item screening tool to identify and prevent elder abuse and neglect in a primary care setting. This index is known as EASY. And its questions are, have you relied on people for any of the following: bathing, dressing, shopping, banking, or meals? Has anyone prevented you from getting food, clothes, medication, glasses, hearing aids, or medical care, or from being with people you wanted to be with? Have you been upset because someone talked to you in a way that made you feel shamed or threatened? Has anyone tried to force you to sign papers or to use your money against your will? Has anyone made you afraid, touched you in ways that you did not want, or hurt you physically? And doctor-provider elder abuse may be associated with findings such as poor eye contact, withdrawn nature, malnourishment, and so on. To the doctor you asked these questions, did you notice any of these or have seen this in the past 12 months? This grant has as its primary feature to embed adult protective service people into a primary care healthcare setting through the WellMed program down in Texas. You refer to APS, high-risk patients, so you can do follow-up. You monitor patients currently at low risk to keep them from going to high risk. And then you do referrals to community resources. This is all part of this grant that is in its second year now. And it's also going to provide for delivery of training to clinical staff on elder abuse risk factors, APS referral mechanisms, identification of abuse risk factors, and also delivery of educational materials. So since your presence, since community health centers are so visible and powerful in communities, it's important that you look in your own community to see if there's a multidisciplinary team already in existence in your community that's addressing the issue of elder abuse. If so, become part of it. Because that's how you get to the core of elder abuse, by having everybody work together in a preventative mode. And hundreds of these coalitions do exist. And on the resource sheet, you can find some more information about it. And I want to add one point about advocacy. And Kathleen sort of alluded to it, but I can do it more than she can, so I have less constraints. There's legislation coming up this week in the Senate that will provide, the president asked for $25 million for the Elder Justice Initiative. Significant for research money and adult protective service money. The first votes on this are going to take place on Tuesday in the Subcommittee of Labor HHS, which I'm sure all of you know what they do. They're the ones who provide money for the HRSAs of the world and everybody else of the world. But that's $25 million embedded in that bill. And if it comes out of the subcommittee on Tuesday, then it goes to the full committee in the Senate on Thursday. Go to www.elderjusticecoalition.com. If your senator is on the Appropriations Committee, and it's on, all of those are there, communicate with them. Educate and inform them. Do not lobby them. Educate and inform them about the importance of this $25 million. It would be very helpful. Let me also quickly shift gears to nutrition, because it's also a critical component of healthy aging and prevention and helping caregivers. You know, in your centers and the work you do, the issue of malnutrition doesn't get a lot of attention either, and it should. Because malnutrition among older adults is very real. Between 2,000 and 3,000 older adults die from malnutrition every year, which is really, malnutrition is when the body doesn't get the proper nutrients, either because they're not eating the right things or the body can't process the nutrients properly. Causes are many. You can't afford the food, there's too many medications and meds that cause loss of appetite, inability to eat due to physical conditions like no teeth, dependence on others for food and transportation. 1 in 4 older Americans suffer from poor nutrition. 80% of older adults, Kathleen talked about this, suffer from chronic disease, many of which could be averted with proper nutrition on the front end, such as hypertension and high cholesterol. And health centers already have a good record in this area. 70% of health center patients demonstrated better control over their diabetes, for those who came in with diabetes, with better patient outcomes because of work that were done in your health centers. So we need to spend some time focusing on understanding and trying to alleviate the problem of malnutrition, because older adults with malnutrition make more visits to doctors and emergency rooms that they don't have to make. Their hospital stays are twice as long, and their costs are $2,000 to $10,000 more than people without malnutrition issues. And they're readmitted to hospitals more often than other patients. And we know how important this issue is in dealing with the Affordable Care Act, with transitions of care. And the other thing to remember is malnutrition is also associated with falls and injuries that cost our nation $19 billion a year. So we'd like to see some solutions and activities focused on. We need to do a better job of helping patients and caregivers make appropriate health decisions. We need to focus on cultural and linguistic competency in our communications at all levels in the healthcare system. And we need to make sure that nutrition is a stronger component of care transition grants that are given out in the future. They're very important that are going out so far, but we need to do more with nutrition at the focal point. And also, there's a resource I gave you related to a new toolkit that just came out on therapeutic nutrition. I call it to your attention. I hope you'll take a chance to look at it. So let me just close with these thoughts. One, we're at a really unique time in history. History plays a huge role come next year, because next year is what we call the anniversary year in the United States. It's the 50th anniversary of Medicare, of Medicaid, of the Older Americans Act, the 80th anniversary of Social Security, and the 5th anniversary of the Affordable Care Act. So each of them are transformational for what they have done, but more importantly, what they can do in the future, if they are allowed to continue and be stronger in the future. So we hope through this conference that you will learn, that you will educate, and then advocate. Because, advocacy is a contact sport. It's a good contact sport. You don't get hurt doing advocacy. But there's 5 things about advocacy, the 5 B's you should remember going forward. 1, be persistent, be informed, be adaptable, be reliable, and above all, be engaged. Thanks very much.
Once again, I just wanted to thank presenters for providing such informative presentations. And now we will open the plenary session up to questions. Does anyone have any questions they'd like to ask any of our presenters? Yes.
I have a question as it relates to adult protection and the federally qualified healthcare centers or healthcare centers. Are there any best practices currently taking place throughout the United States? And if not, I have 3 regions and I'd like to go first.
I'm not familiar with any, but that doesn't mean that we don't have them. So I can definitely bring that back to our group. I don't know if anyone else has anything to add, but I'd be happy to talk with you afterwards.
I think it's an opportunity.
Yeah.
Many times our healthcare centers are a valuable resource that we don't know about, and conversely, they don't know what we're able to offer as it relates to the administration for community living. It's a perfect marriage, and I think adult protection is a perfect fit. So I think it's a great opportunity.
And the other thing I'd add to that is that the one thing that you are getting in the qualified health centers that the Elder Justice Act is not is money. You're getting good money. You're getting good money. I mean, I got to tell you something. You're fascinating. You're bipartisan in your money. I mean, the Bush people supported health centers. The Obama administration is doing the same thing. The Affordable Care Act gives another boost to it. We want to be on your train, in the elder abuse side of things. So we need to talk about those strategies down the road, I think.
Does anyone else have any questions? Yes.
Hi, good morning. I think 2 or 3 of you mentioned the preventative services that Medicare is now focusing on for the elder. I gave a talk this weekend to 50 or so very well-informed older individuals, and none of them knew about the annual wellness visit. I'm wondering what kind of public service awareness campaign is going on in the country. Again, they were very well-informed, very well-educated, and that was the focus for them, is what is this you're talking about? The annual physical is not being paid for, but this annual wellness visit is. And none of them had heard of it. So we're not doing a good job getting that out there for them.
No, I mean, it's unfortunate that's true. I mean, I've heard some of those same things, and I think some of this, and I'll try not to get too partisan here, but I will for a second. But some of this is about the the messaging that went out about the Affordable Care Act to begin with and what it was supposed to do to Medicare instead of what it was supposed to do to help Medicare. Okay? And that messaging got really heavy-handed going down the road. It impacted the way older voters changed their political views. And as a result of that, I think they lost knowledge about, never got the messaging about the positive aspects of the Affordable Care Act and Medicare. The hope is now that we're beginning to change that around and there's more of an activity in that whole thing. But I think some of that had to really do with the early stages of messaging and failure to promote the positive aspects of the Affordable Care Act on Medicare.
I just want to mention I just became Medicare eligible, and when I knew about the wellness checkup, but was never informed, so I went back to the Social Security office that I was using and said, hello, why don't you do this? And in fact, they have made a change, so sometimes it takes a little effort.
Great. Just to kind of dovetail off that, I have a question for you, Andrea. You talked about some of the lessons learned from the health centers with their outreach and enrollment, the PCAs, et cetera. Do you guys have any plans to kind of revise the formal training based off the lessons learned to kind of improve it?
Sure. So actually right now, health centers are in the process of talking to one another and working with their primary care associations to do some debriefing sessions either within their state or regionally. So they're gathering those right now. As far as the training for health centers to become assisters, that's really a little bit of the role that we gave primary care associations to assist health centers in understanding what those requirements were per their state. So it really depended upon whether or not they were in a federally facilitated marketplace versus a state-based marketplace, and the training then would differ. So most of the training in a federally facilitated marketplace was the training that CMS provided to them. So HRSA didn't have as much of a role in developing the training, but I know that our colleagues at CMS are revising their training now.
Okay, great. Did anyone else? Yes, you.
A question for Dr. Karpiak. I'm wondering, out of curiosity, do you see any differences in demographic or socioeconomic status when you're looking at older adults diagnosed with HIV versus a younger population that's diagnosed with HIV? And I was really taken by the campaign and the bus ads and that sort of thing. And I see those as, they're very broad. And then I'm wondering, is there a more targeted approach also to getting that message out and really looking at those demographics as well?
The people who are at highest risk for HIV infection, be they young or older, are people of color, largely African American and Latino. 20% of all new infections are gay white males. So it used to be the case; it was the opposite in the 80s. So there is target, and in fact, the perfect host for HIV is a poor person. There's no question about that, for a variety of reasons, which we could spend the whole day talking about. So if you want to look at risk, it's certainly economic status and your ethnicity, so for sure.
That's not, I wasn't sure if it was different for the aging population.
No, it's the same. In fact, sadly, in the 20 to 30-year-old age group, HIV infection rates are literally out of control. And they are largely in African American and partially in the Latino community for reasons, I don't do research on prevention, but for reasons that those who do don't have an answer to. It's actually very, very frightening within that younger age group. We do see increases in the over 50 age group for sure. They're not huge, but I suspect that as that population grows, as I mentioned before, and they have the virus because they're not cured, that we're going to see higher transmission rates occur.
Great, thank you.
Bob? Yes. Talk about questionnaires, the 5 questionnaires that this experiment in Texas. When is the experiment going to be concluded, and how are they going to share it with the rest of the population?
Good question. The question had to do with the grant I mentioned out of the state of Texas. It's the second year of a third-year grant, so the end of next year, I think the final aspects of the grant will be released, but there are interim steps, interim findings that are coming out. And if you go to our Elder Justice Coalition website, and I'll give you a card afterwards, I'll keep you posted on what Actually, there's some developments that just occurred last week, but I didn't have enough time to get them into my presentation. But they're showing some progress already, and I think it's just it's a culture shift to some degree of, because part of what this whole elder abuse prevention issue is about is connecting people who never talked to each other before. People in the APS world who never talked to somebody in a qualified health center, or even physicians talking to adult protective service people. Everybody's got a role in this deal, but unless people start talking to each other and identifying the fact that they've all got to come together on the prevention side, we're going to keep struggling here.
Yes.
I had a question actually about the big year next year, all of the things that are happening. I heard in the introduction that you were part of the White House Conference on Aging in '95, so that would also be like 20 years later. Has there been any move to have another White House conference that emphasizes all the things that are going on and any other kind of things that will make a difference? I do believe that the Medicare part of it has been emphasized, as
Right.
you've said, and this would be a good time to emphasize the positive things. It's not just the Affordable Care Act, but all the other things you mentioned.
I'll offer my perspective, and I'm sure Kathleen may have a thought representing the administration here. The president has asked for $3 million for a White House Conference on Aging to be held next year in his budget. That same committee and subcommittee I talked about earlier that's got the elder justice request also has the White House Conference on Aging request in front of it this week. That is a signal of interest. The reality of it is that they're trying to put together a plan to do some kind of White House Conference on Aging, perhaps different than the ones that preceded it, but built around the anniversaries, if you will. But the details of how they'll do it and who's going to do what are in the hands of the administration. But I think the consensus among the advocacy groups, for the most part, and Sandy can maybe talk about this as well, is that we need to have another one, and we need to have it focused on long-term care in particular as a very important component of our future. But I also would point out that there's an important conference going on in about 2.5 weeks, the White House Conference on Working Families, that I think is going to be addressing a number of issues that I think could be a good forerunner. Some of the topics they're going to take up on caregiving and other things could be a good forerunner for a White House Conference on Aging to be held next year.
Great, thank you. Actually, Mr. Blancato, I have a question for you as well, because you mentioned malnutrition. Have you guys done any work or research, or do you have any training on ways to kind of overcome that stigma that's associated with receiving SNAP benefits, especially among older adults?
That's a very good question. First of all, I think the reality of it was that when the last farm bill, not the current farm bill, but the one before, it was passed with an understanding that of all seniors who were eligible for SNAP, less than 1/3 were getting it, okay? And our colleague from the National Council on Aging, on whose board I proudly sit, has been doing fabulous work on the whole question of SNAP outreach to older people. The stigma issue is part of it, but it's the awareness issue that you're eligible that's a bigger part of it. Access to benefits is a critically important issue for people of all ages who are poor, but especially older people. It's amazing to the degree to which they do not know they're eligible for certain programs. So you need that intervention, and the Administration on Aging has been funding a benefits center for a number of years. Sandy runs the Elder Care Locator Program, which is another means of guaranteeing people's access to things. The other part that's important too, though, is that in the broad sense of things, not only was there expanded outreach done in the last set of Farm Bill, but the minimum benefit was raised, because that was another issue. People were saying, why should I go through this hassle of filling out papers if all I'm going to get is this amount of money? But we've got to address the larger question of all the programs in the Department of Agriculture and in HHS that provide nutrition for older people. SNAP, Senior Farmers Market, Older Americans Act Nutrition. But it's also about raising the awareness about things. We should be more vigilant about looking out for people who are struggling to eat on a regular basis. So work is being done, and I'm sure much more will be done.
Great, thank you. Do we have any more questions? Yes.
As part of the campaign to inform seniors about the need for HIV testing, have there been any efforts to do mobile rapid testing in senior living communities?
we've tried this in New York City, and I know that one of the later speakers today from Baltimore has made efforts to do that. So I think that there has to be more of that. And I think part of the reason that that works is that when you see people go to get tested, it starts to break down the stigma. So that I think this is also very dependent on each community, how best to do that. But we have done it in New York. It's still a kind of heavy lift because of the stigma associated with it, but it does work, and people certainly have been detected.
Thank you. Unfortunately, now it is time to end this first plenary session. I want to thank you guys for having such an engaging question and answer session, as well as offering such informative presentations. Thank you.